Good morning, everyone. Presenting 6 spindles on behalf of Medicine 1. This is a case of a 19-year-old gentleman who's Mr. A, BTech student from Jharkhand, who presented with weakness of all 4 limbs since 2 years. He gives a history of difficulty in running while playing football. He felt he was slower than his peers. However, there was no history of swaying from side to side or tripping and falling. He had difficulty straightening his back after bending down to pick up objects from the floor, which required increased effort and time. He gives history of hips tilting to either side on prolonged standing, and history of difficulty climbing up the stairs and getting up from squatting position, and also difficulty lifting arm above head. However, there was no history of slippers falling from the feet or no difficulty in dressing or mixing food. There was history of thinning of muscles present and occasional cramps. And however, no history of contractures, wasting or fasciculations, no fatigability or diurnal variation, no exercise-induced cramps or high-colored urine, no sensory involvement, no history suggestive of cognition, cognitive involvement, cranial nerve, cerebellar or bowel-bladder involvement. No history of skin rash, photosensitivity or arthralgia, and past history-wise, he's nil comorbid and not on any medications. Birth history, he had normal developmental milestones. He has a significant history of his elder sister having similar complaints of difficulty climbing up the stairs and hips tilting on prolonged standing. On examination, he was conscious, cooperative, and oriented. Vital signs are normal. General physical examination, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. However, stria was noted over the trunk. Coming to central nervous system examination, his higher mental function was normal. Cranial nerve functions is normal. Motor system, the attitude of his lower limbs is externally rotated, and tone was reduced in all 4 limbs, and bulk was symmetric bilaterally in the upper and lower limbs. On inspection, he had calf hypertrophy bilaterally and diamond and quadriceps sign in his lower proximal limbs, and Goa sign was present, and wasting was present in suprascapularis, pectoralis, trapezius, rhomboids, and biceps, and mild wasting of hypothenar eminence with wasting of hamstrings and hip adductors, and winging of scapula was present bilaterally. He had reduced power in the shoulder abductors, the elbow flexors, and hip adductors, and hip extensors as well. Sensory system examination was normal. Deep tendon reflexes was 1+ in bilateral triceps. Rest all were absent. He had a Trendelenburg gait. Scoliosis was present. Other systemic examination was normal. So this is a clinical syndrome of a 19-year-old boy who came with complaints of progressive pure motor element weakness of all 4 limbs, the proximal more than the distal muscles involved, and the lower limb muscles predominantly than the upper limbs with areflexia.
So she's given you all the clues, certain answers. Yeah, go on.
Thank you
Because
for the response.
the answers are repeating. Except for one Emery.
The anatomical localization is the muscle because it was the bilateral symmetrical proximal limb weakness of the upper and lower limbs. It had a limb girdle pattern with muscle selectivity, and the characteristic feature was weakness more than the wasting. Reflexes were absent, which is a late feature in muscle disorder, and fasciculations are also absent. Whereas an anterior horn cell, it is an asymmetrical weakness with distal more than the proximal involvement, wasting more than weakness, and reflexes are lost with fasciculations. And we also ruled out root muscle and nerve because there was no sensory involvement, and NMJ involvement because there was no fatigability or diurnal variation. So the myopathy, the inherited causes of myopathy are considered because of the long-standing history of 2 years history of weakness of all 4 limbs, muscular dystrophy. The first differential was Becker's or limb girdle muscle dystrophy, and the others, facioscapulohumeral dystrophy was also considered. Congenital myopathy, metabolic myopathy, and channelopathies. Metabolic myopathy and channelopathies are generally episodic, whereas this patient had persistent muscle weakness, and ruling out acquired causes also because they're generally acute or subacute, and there was no history of toxin or drug induced myopathy from his history as well, and no history suggestive of inflammatory myopathy from his history. So the top differentials just considered were Becker's and limb girdle muscle dystrophy. Becker's is an X-linked recessive disorder with a defect in the dystrophin gene. The onset is generally 5 to 60 years of age. Dilated cardiomyopathy is present, however, mental retardation is absent, and the treatment is supportive with physiotherapy, occupational therapy, and cardiology follow-up. Steroids slow the progression of the disease in Duchenne's muscular dystrophy more than Becker's muscular dystrophy. Still, there are no evidence suggestive of slowing of the progression of disease by steroids. And coming to limb girdle muscle dystrophy, it has 2 types, LGMD1 and LGMD2. LGMD1 is an autosomal dominant disorder, and LGMD2 is an autosomal recessive disorder. They present between the 1st to 4th decade of age. Males are affected equally as females, and it is a slowly progressive proximal upper limb and lower limb involvement is present here. Cardiomyopathy is present. There is a type of LGMD which is type 2B called dysferlinopathy, which has significant upper back muscle wasting, and diamond on quadriceps sign, which is the atrophy of the vastus lateralis and sparing of vastus medialis. And treatment here is again supported. On investigations, the urinalysis showed RBCs of 35 per high power field and blood 2+. Urine phase contrast microscopy showed isomorphic RBCs. CPK was elevated. The EMG showed a myopathic pattern with no sensory involvement and no active reinnervation potentials. SGOT was elevated more than the SGPT. CRP was normal. ANA was negative. Calcium phosphate, TSH, vitamin D was normal. Echo showed no conduction abnormalities, and ECG was normal. These are the 6 patterns of persistent weakness. The first one is a proximal muscle weakness more than the distal. We consider muscular dystrophies.
Gladiss, we are going to be 9 o'clock, so finish first.
Yeah.
We need one more. We have one more presentation. Yeah.
So we think of muscular dystrophies in this case when the proximal muscles are involved more than the distal. The other pattern is ptosis with extraocular muscle with ophthalmoplegia and pharyngeal muscle involvement, which is oculopharyngeal muscular dystrophy, and facial weakness with scapular winging, which is facioscapulohumeral dystrophy. And similarly, myotonic muscular dystrophy, which has the classical hand grip myotonia, and dropped head syndrome because of the weak extensors of the neck, where we consider myasthenia gravis, ALS. So the investigations, which confirm muscle disease, the myopathic pattern in EMG. CK elevation supports myopathy. And DNA genetic analysis is a gold standard for diagnosis of inherited myopathies. And muscle biopsy will help distinguish disorders which are inherited myopathies which are not distinguished by genetic testing, or muscle biopsies are generally done for acquired causes of myopathies. So this is a genetic analysis. This is an article from PubMed which highlights the genetic analysis, whole exome sequencing for the diagnosis of limb girdle muscle dystrophy, in which they employed a cohort of patients. They employed families, 60 families, which in whom the limb girdle muscle dystrophy was not diagnosed based on protein-based analysis and targeted Sanger sequencing. These families had patients who presented with more than 2 years of muscle weakness. And out of these 60 families, 27 families, known myopathy genes were identified with whole exome sequencing. And out of the 27 families, 15 families had genes related to LGMD, and 12 families had genes related to LGMD, and 15 families had variants not typically associated with LGMD. So the diagnostic success rate of this genetic analysis was 45% in this, which could diagnose the so-called difficult to diagnose cohort of patients in LGMD. And I would just like to highlight a gene therapy, which is in the preclinical trial phase. It employs the enzyme acid sphingomyelinase, which is attached to the vector AAV, adeno associated virus, which is a potential therapy for limb girdle muscle dystrophy type 2B, which is dysferlinopathy. It is based on the concept that dysferlin is a protein which leads to increased secretion of ASM, and ASM is essential for the sarcolemmal repair, which in turn prevents the muscle degeneration. So since the gene for the size of the dysferlin gene is large enough, they've tried to insert the gene for ASM to the AAV vector, and mouse models were employed, and it led to increased secretion of a single injection of ASM AAV.
Points you want to make, because you already crossed so many minutes. You continuously, you have to consider other people also, no? So you're introducing a new mouse model which they are trying a gene therapy. It's in the pre-animal model. What are the other points you want to make?
Yeah. So in our patient, we advise ambulation supportive care, ambulation physiotherapy, and respiratory muscle exercise. And he was his genetic analysis is awaited, whole genome sequencing is awaited, and sister was also advised genetic evaluation. So the learning points from this patient was the patterns of persistent muscle weakness, and genetic analysis with whole exome sequencing diagnosed 45% of the difficult to diagnose cohort of LGMD, and ASM AAV is a potential gene therapy for dysferlinopathy.
Any questions from the audience? It's a good case for final year MD students to examine and present to a neuro. Thank you, Gladiss. We'll go on to the last case by Dr. Sivaranjani, tracing the nerve.